Welcome to The Point of View. This is your favorite current affairs show on television. Here on The Point of View, we get the right guests. We ask them relevant questions on issues that matter to you. And we are firmly in COVID-19 territory. So, first case in Ghana, 12th March. Today is 11th May. So, it's 2 whole months of COVID-19. And we're going to try and understand where we are with our numbers and what the numbers mean. We have 4,700 cases and I have a very interesting panel who will be analyzing all the dimensions of our numbers. So the case count, our recoveries, our case fatality, and of course those who are critically ill and unfortunately those who have died. We want to make it interactive, so if you have a question or a comment, there's a WhatsApp number on the screen. Please get in touch with those. And if you're watching on social media as well, you can comment on the stream. When we come back, I'll tell you who my guests are. So we'll try and get a clearer sense of where Ghana is. If you look on the COVID-19 global map, our circumference, which represents our case count, has gone pretty high. So on the 12th of March, we had 2 cases. It took us 50 days, that's end of April, to get to 2,074. And between 1st May and 8th May, we are now 4,700. So what we did in 50 days, we've done in 7. So what's really going on with our numbers? Also, how concerned should we be that only about 10% of our people have recovered? What about the 22 who have died? That case fatality is very low. How much should we shout about this? We'll ask all those questions to my very exciting panel. So I have 3 panelists joining me on Zoom, and 1 will join me in the studio. So on Zoom, I have Dr. Grace Ayensu Dankwa. She is a politician, a trauma emergency specialist, and a member of the NDC's COVID-19 technical response team. Doc, good evening. Thanks for joining us. Hello, Doc.
Hey, Bernard, how are you?
I'm very well. Great to have you. I also have Dr. Kenneth Techi. He is the General Secretary of the West Africa College of Physicians and also a consultant physician. Doc, great to have you. Good evening.
Thank you, Bernard.
Great. I have Professor Alfred Yorson, who is the Vice President of the Ghana chapter of the West Africa College of Physicians, and is also an Associate Professor, University of Ghana Medical School. He's actually the head of the Department of Community Health. Professor Yorson, great to have you.
Thank you very much. Glad to be here.
Great. And of course, later on in studio, I'll be joined by Dr. Justice Youngson, who is the General Secretary of the Ghana Medical Association. He will join me in a few moments. So let me refresh everybody's memory by taking you to the President's statement yesterday, just a few minutes of that. He addressed his 9th in the series of briefs on COVID-19. So here's an excerpt of what the President said to the nation about where we are and the measures he was putting in place.
The country has conducted a total of 160,501 tests, with our total number of infections standing at 4,700, with 494 recoveries, 5 persons being critically ill, and 4,179 persons responding to treatment. 22 persons, virtually all of them with underlying illnesses such as hypertension, diabetes, and chronic liver disease, have unhappily died. We must understand that the more people we test for the virus, the more persons we will discover as positive, and thus have the opportunity to isolate and treat them. If you do not test people for the virus, you will not find the persons who are positive, let alone isolate them from the population and treat them and prevent them from spreading the virus. Indeed, had we not been proactive in undertaking enhanced contact tracing of infected persons and had relied solely on testing persons who reported to hospital, which is the practice followed by some other countries, i.e. routine testing, our total case count would have stood at 1,413. The other 3,232, i.e. 2/3 of the population of positives, would have been undetected and still be within the population unknowingly infecting others. I've come into your homes to announce that the ban on public gatherings, as set out in Executive Instrument number 64, has been extended also to the end of the month, i.e. 31st May. So during this period, there will continue to be a ban on public gatherings such as the holding of conferences, workshops, parties, nightclubs, drinking spots, beaches, festivals, political rallies, religious activities, and sporting events. All educational facilities, private and public, continue to remain closed. There's still a ban on funerals, other than private burials conducted with not more than 25 persons. It is noteworthy that the police are arresting and prosecuting persons, irrespective of their status in society, who flout these regulations. We cannot allow a few persons.
So that was the president, and he is quite firm in his decision to continue with the ban in public gatherings. So there are 3 levels of measures. There's the closure of the borders, which has been on since the middle of the month of, actually last week of March. Then we've had the lockdown, which has been subsequently reviewed, and of course we have the ban in public gatherings. So let me tell you about the numbers. So Ghana has 4,700 cases, of which 4,184 are active. 22 people have died. The country Ghana has the most cases in West Africa. Nigeria follows with 4,399, and then there's Cote d'Ivoire, Senegal, and Co. In fact, the Greater Accra region has more cases than all West African countries except Nigeria. So what's going on? Should we be happy that we are testing more, therefore we are catching more fishes, or should we be worried that there's a lot of fish in the pond? Let me start with the panelists on the phone in Zoom. Let me start with Dr. Techi. Doc, from the perspective of the West Africa College of Physicians, when you look at the West African sub-region and you see Ghana with 4,700 and Nigeria 4,399, and then Senegal with 1,886, and then the other countries with fewer numbers. What does this say to you? Is it a testimony of our testing, or is it a question of the thing being endemic here? What are your initial thoughts, Dr. Techi?
Hi, Bernard. Thank you for having me. Well, my initial thoughts, with regards to Ghana, is that we are excited that we are testing so many cases and picking up a lot of positives. What that tells us is that we can be able to control the community spread. But also, these numbers have to be interpreted cautiously, okay? Because I'm looking at a situation where, yes, we have done over 160,000 tests, and we have picked up about over 4,000 cases. The other countries have done fewer tests, for example, Nigeria, but they've picked up almost, an equal number of positives. Now, it doesn't mean that we are better off than them, because, from speaking to colleagues in Nigeria, they have a different approach to testing. So whereas we are doing a lot of community testing and testing asymptomatic patients or individuals, Nigeria is focused more on testing people who are, so they are doing more hospital testing. And so when you do that, you have fewer tests, but more positive, because these are people who are ill and are presenting to the hospital. So yes, and I cannot say the same for Ghana, that we are doing that many in-hospital tests. So maybe, just maybe, that is why our positivity rate may appear to be lower. Okay, so we have to look at the details in the test. Yes, in the other region or countries in the sub-region are a bit more constrained, because yes, we know that the outbreak of Ebola affected the health infrastructure of some of these countries. So they may not have the capacity to test as much as we are doing. And maybe, again, that is the reason why their numbers are lower. But with regards to, say, Ghana testing a lot and picking up fewer cases compared to other countries that have tested fewer and have picked up almost similar cases. I'll say the differences may be due to how and where we are testing.
So for you, the numbers are a testimony of the testing, pardon the alliteration. Is the testing that's bringing the numbers. So we should.
So yes, certainly.
Okay.
Certainly, the more you test for this disease, the more likely that you would pick up positives in the community.
Good. Let me take.
Once the disease comes into the country, there's likely to be community spread.
Fair enough, Professor Yorson. Apart from your role at the West Africa College, I know you also head the Department of Community Health, and we are talking about community transmission, and we are talking about community testing. So the word community is key for me. When you see 4,700 by Ghana's name, and you see 4,399 by Nigeria, and you see 1,008 by Senegal, what emotion does that give you, Prof?
Yes, Bernard. It basically boils down to the type of population that you test and how you conduct the test. You know, Ghana, we started quite aggressively testing all those who were coming into the country and tracing their contacts into the community. Once you do that from an initial early point, you are going to test a lot. You may not glean a lot from the test because these are contacts of persons who came in and they are also contacts of others. Once you go in at that early stage, you are not likely to get so many positive tests. But that in itself is a good sign because if you had allowed these people to stay in the community without knowing, they were going to be the transport. They were going to transmit to other persons in the community. So it's all because of our approach to testing and because we have devised a capacity to test so many, I think itself is good. We will need to go ahead and test so that we remove as many potential persons who could be transmitting within the community as possible. We may not have capacity to test everybody, but we will continue to do the testing. And even if people are not sent to isolation, people will know their status, and we hoping that people will do what is right and protect others from getting the condition. So the numbers in itself is going up, yes, but it's because of what we are doing in trying to contain the pandemic.
So you are not worried about the 4,700 in a rate of growth. You are saying if other West African countries had been testing as aggressively as we had, they probably have had equal or more cases. So we shouldn't be too concerned.
We should. 4,000, almost 5,000 is a concern. We should be worried about it. However, what we need to note is that once we have community spread now, the disease is within our community and it is going to spread. If you don't test, you might try and hide or put down the numbers and things because we are not testing.
Okay.
The numbers are few. It's not true. Once it is established in the community and people are not doing the social distances, not wearing the mask, the disease will spread and the numbers will continue to be worrying.
Okay. Let me take Dr. Thank you for your comment. Let me take Dr. Grace Ayensu Dankwa's comment. Before that, let me just say Dr. Justice Yankson, Ghana Medical Association is in the studio. Doc, give us a wave. Yes, he's here. I have your statement here and I'm going to read it to you later on. Thank you for being on the show. And I put on my mask because he came. I don't know where he's coming from, so I don't want him to come and give me anything. So, Doc, it's not because I don't like you, but it's because these days you can't be too sure. Dr. Ayensu, good evening. Thanks for joining us again. What does 4,700 say to you and the team you're working with? What are your concerns about that number?
4,700 makes me very, very concerned. I mean, we're at the exponential phase of our curve. Our numbers keep going up, even especially since the lifting of the lockdown, our numbers have increased significantly and exponentially. and I'm very, very concerned. The testing argument that because we are testing more, that's why we're getting more numbers, does not hold water. It doesn't add up. We are testing more and people are getting positives because we have not curtailed the horizontal transmission. That is why we are getting more test positives. Because if you test more and there is no transmission, people are not infecting each other, or the asymptomatic individuals are not infecting each other, you will get test negatives. So the fact that you're getting test positives has nothing to do with the fact that you are testing more.
But if
the test positive shows that you are still, the transmission is still going on. People are still spreading the disease. That is why you're getting test positives. And in fact, when you test and you get the positives in the community, it's a good thing, because those are the individuals you want to remove from the community.
So it's a double-edged sword. It's good you are catching the people, but you should be worried that the transmission is going on.
It's good you are catching the people, and you even want to catch the people more. Because, for instance, yesterday the president said one person infected 500 people in Tema. That implies that one individual was able to infect 500. That implies that that one individual, even when the person was positive or maybe asymptomatic, was able to go through the community and infect 500 people. That means that our contact tracing of that one individual may not have been very robust or even very good. So testing more people is not an excuse to say that that is why our numbers are high. Because you can test 100 people, and if there's no local transmission, then you get 100 negatives.
But you can also have 100 positives. If you don't test them, you will not know, and therefore you think you are okay, but you are not.
That is precisely why we should test even more. So that is the point. I think you're agreeing with me that that is precisely why we should test even more, because you're looking for that asymptomatic person who has no symptoms, doesn't have a fever, doesn't have a cough, is not short of breath, but is positive or is infected. So testing more, even more, is what the government should do, precisely because of the case that the president reported in Tema yesterday. One person has infected 500 people. Those 500 people also, each one of them has several contacts. Based on that, we cannot get 100% of those contacts. So that means that the local transmission is even more, and the disease is spreading even more. Even with the lockdown and after the lift of the lockdown, we have gotten worse numbers.
Okay.
So I am extremely concerned and worried about those numbers, and
Good.
Nothing about it, and no argument about the testing makes me even feel more comfortable.
Good. Let me come to Dr. Youngson. Your group issued a statement on the 9th urging the president not to lift the ban on social gatherings and for religious activities. This was before we got to 4,700. When you issued this statement, we were around 4,300. So why were you urging him not to lift? What is the emotion? Are you guys alarmed? Are you concerned? Is it normal? What's the emotion in the GMA about our numbers?
Okay, so Bernard, good evening.
Good evening.
For us as the GMA, we have our members, that includes all my co-panelists. Truth is that we are also evaluating what is happening. Whatever happens at the end of the day, technically speaking, will also end with us, because we are the ones going to provide the care. We also know the structure of our health system, how robust or otherwise that it is, what it can contain and what it cannot contain. Now, we are also looking at what the community spread is actually doing to all of us as a people. The figures are going up, and it's not just the figures, but in terms of geographical location, you realize that gradually we started from 1, 2 regions, now 13 and counting. So you could also see that traditionally it looks as if Accra had been a very hot spot for all of us. This is where it all started from. Some of the regions are also beginning to register higher numbers. As of today, Obuasi has actually surpassed Kumasi in terms of the numbers. And this basically tells you that the community spread is beginning to gain a lot more ground. 2, we've also noted that anytime there is testing that involve groups of people, so like the Tema factory, so let's say a construction site, stuff like that, you almost always will pick huge numbers of persons who are infected. What it tells you is that within our communities, right down from, with all due respect, those in the lower social classes to the middle to the upper, it is permeated. If you take regional basis, we are having cases across board. If you look at parameters in terms of gender, we have both. We have kids involved, we have the middle age, we have the elderly. So gradually, every fabric of our society is actually being, taken over by COVID-19. Now, when you juxtapose the increasing numbers and the rates at which we are growing to the sort of health facilities we have, then you can realize that we are in trouble. Mind you, not long ago, the president said there are 88 districts without even district hospitals. So imagine how things are going to look like. If you've listened, the Director of Clinical Care for the Ghana Health Service has even made some revelations that, look, from where we sit, patients that were cared for in the hospital are getting better outcomes and recoveries compared to those who were going through the home care. What it means is that if we don't take time and our health systems are overwhelmed, a lot more people, technically speaking, will not get access to medical care. And what it means is that even the deaths that we are worried about, in quotes, we seem to think that it is not so much as of now.
Could go up.
Could go up. Okay. And that could be our bane.
That's your preliminary comment. Let me go to the second point this evening. So I'm starting again with Dr. Techi. So every time we talk about a country, they point out 4 things: confirmed cases, recoveries, deaths, and active cases. So those seem to be the 4 top lines. Question: how concerned should we be about Ghana's recovery rate, which has stubbornly remained around 10% since we started looking at the numbers? And again, using the West African context, Ghana has 494 recoveries out of 4,700 confirmed. Nigeria, out of 4,399, has 778 recoveries. Senegal, who are close to us in terms of 1,800 cases, have 715 recoveries. So almost all our neighbor countries, Guinea, 2,146 cases, 714 recoveries. Again, from the West African perspective, Dr. Techi, how concerned should we be that our recoveries are around 10% when our peers are over 25% in terms of recoveries? Doc, are you there?
Sorry.
Doc, are you there?
Hello.
Yes.
Yes.
Did you get the question?
Great. Yes, I did.
Go ahead with the answer.
So I was saying that I'm not sure that we should be too concerned about the recoveries because of a number of things. One, it is not like these patients who are positive are going to get any. Most of them are asymptomatic anyway. So if they are asymptomatic and we are not treating them, then we can as well just wait until whenever they decide to become to recover. In recovery, in this case, meaning that they test negative twice. Now, the guidelines suggest that to declare somebody as recovered, they should have tested negative twice, at least 24 hours apart. The challenge, however, is that in Ghana, I think the testing is done almost a week after the first test. So if you test negative, we tend to wait for about 7 days before we test you again, just to be double sure that you are negative. Because in the beginning, when the testing was being done 24 hours, it was realized that some people remained positive even after the first negative. So it was extended to about 7 days. Some countries just do one negative test and they declare you recovered. So again, this can be something which is affecting the recovery rate. The other possibility, and I guess it's also affecting our recovery rates, is that if we are not able to track all the over 4,000 people who are positive, we are not going to be able to follow them and see that and record that they have recovered. And as you are aware and we've heard in the media, some people, when they have tested positive from this enhanced surveillance, are not able, or we are not able to pick them up for follow-up. So for me, these are some of the reasons that maybe our recovery rates have remained low. But I don't think that that should be a worry, especially when many of these patients are asymptomatic. And if we identify them and quarantine them, then we can just wait until they become negative, and they will eventually become negative.
Professor Yorson, what's your view about our 10% recovery rate?
Yes, certainly. Like Dr. Techi said, if you have over 92% of the total population of people who have tested positive as being asymptomatic, that is, these people are not showing any signs and symptoms, and then your recoveries are not as high as you are expecting, then there is something that is creating this, and not necessarily that our patients or our cases are not recovering. And that's what exactly Ken has explained. We test the first one and we wait to test after 7 days and several days before we even get the test result. So there are challenges, administrative challenges, which is real, and not that our patients are not recovering. So I agree with Ken, we wouldn't be overly worried about our recovery rate, unless of course we can be shown and proving that we are having so many number of deaths coming into our facilities, or people are dying in the communities that are not explained. If we can have evidence of that, we will be worried. But if we don't, and our people are asymptomatic and they have immunologically not seroconverted as negative, but they are asymptomatic, the challenge there is that we still need to keep them isolated before they transmit to others. But in and of itself, we won't be worried that our recovery rates are low. Again, we need to be able to trace all the people who we have initially tested and are positive. It's only when you are able to trace them, get them tested again, then we can say that, yes, these have recovered. So it is a number of things. Data, tracing them, getting them tested, delays in our testing and getting the result and declaring them, they are all factors.
All right.
But as I said, we are not overly worried because these are 92% and over asymptomatic tests. Unlike in the UK, US, and others, where the pandemic is showing a different trend. People get it, they get seriously sick, and they are counting their deaths and all that. That creates a different scenario.
All right, let me take Dr. Grace Ayensu Danko on this. How concerned should we be about our 10% recovery rate?
I think we should be extremely concerned, because that is precisely the problem. And that when I hear my colleagues on the panel saying that, oh, it's not a concern, some people are lost to follow up, some countries, they're only testing one. What country is only testing one, Bernard? There is no country only testing one. I mean, unless they can prove that some country is testing one. When you see that our recovery rate is that low, South Africa, even Niger is higher than us. Most of our African countries are higher in terms of recovery rate. It tells me two things. First, it makes me very concerned. And then it tells me two things. Perhaps our health system is an indication of the robustness of our health system. That maybe when the people, because you know that the COVID-19 in terms of the epidemiology or the nature of the disease is that when 10 people get infected, only about 3 of them will really be sick and get to the hospital and need hospital care. 7 out of the 10 will be mild symptoms. So they will have a little bit of fever or cough or maybe sore throat, but they will get through. So that is just the nature of the disease. The 3 that gets into the hospital out of the 10 are the ones that most likely maybe are older, they have some comorbidities, they have diabetes, hypertension, maybe they have cancer or other diseases that have made their immune system low. So if those people are the ones, when they get into the hospital, are not recovering, then it's a problem. That implies that maybe our health system is not very robust. That means that when people get into our health system, they are more likely not to recover. That is what that number means. So when you see that in terms of all of the African countries, that Ghana is like number 16 with a 10% recovery rate, I am very concerned, and it's raising to me what we call a red flag. That means we have to look at our health system, and we have to look at how the people go through the system and why our recovery rate compared to countries like Niger, South Africa, and most of the other African countries, why we are low. It's not a number to blow off and then the argument that it is maybe due to what we call loss to follow up. In other words, somebody came, the person was tested positive, and then they tested negative, but we couldn't find the person in the system. When you are losing a lot of people to follow up and is affecting your recovery rate, that is even more of a big problem and even a bigger red flag, because you should not lose people you have flagged as this person, the person that I should follow up. Okay. In my medical practice, when people are lost to follow up, I get more concerned, because once they are lost to follow up and you're not sure whether they've actually tested negative or positive, and you should be following them, but you can't find them, that is even more of a red flag. That means that your system of tracing and testing and follow up is wrong. That means there's something you have to adjust your system to catch all those people within that system.
All right. Thank you, Doc. We will take a short break. We're talking COVID-19, the reasoning behind the numbers. First question, should we worry about the 4,700? Second question, should the 10% recovery rate worry us? We have other questions. When I come back, I'll ask Dr. Youngson of GMA his view on the recovery rate. And then there are other issues about case fatality and other numbers which have come up. We'll try and remove the veil on all of those. In the meantime, send us your comments on the WhatsApp number on the screen. Stay with us. Welcome back to The Point of View. Tonight we're talking COVID-19, unveiling the reasoning behind the numbers. My guest, Dr. Kenneth Techi, General Secretary, West Africa College of Physicians and Surgeons, and a consultant physician. Dr. Grace Ayensu Dankwa, politician, a member of the NDC's COVID-19 Technical Response Team, and also a trauma emergency specialist. I also have Professor Alfred Yawson, Vice President of the Ghana chapter of West Africa College of Surgeons and Physicians, and also ASO Prof, University of Ghana Medical School, Head of Department of Community Health, and then Dr. Justice Youngson, General Secretary, GMA. Doc, is the GMA concerned about our 10% recovery rate?
Well, there's a concern, and there are two sides. The first is that the testing regime has also posed some challenges when it comes to ramping up the numbers of the recoveries. What has happened is that you go in for your first negative, you need to wait a week for the second negative. But you know the problems with the testing, the delays I mean. So once the second test is done, it will take you, prior to probably the last couple of days, it will take you between another 7 to 12 days before we get the results. So until we get that results, we cannot add you to the recoveries. And that has posed a challenge. But the bigger problem with this is that if you still have a lot of people in the system who either haven't been found and tested or are yet to get the two negatives, what it means is that these persons potentially can also spread the disease. So if you have that lower rate of recovery, and you also have a lot more of the people being out of the health facilities, and we all are very much aware of the challenges associated with the home care. Some people are just not respecting the rules. Then these people potentially could be spreading the disease and that will keep adding to our numbers.
But are
and
you
that
aware that
poses
in
a lot more risk?
Some countries, they use, I'm told that WHO has 2 ways of determining recovery. One is the double negative test, and in some countries, I'm told if you have 14 days of no symptoms, they allow you to go home.
Well, that is the prerogative of the country and their health authorities. Some will choose what we have chosen to do, which I think
so
is
ours
good.
is more rigorous.
It's more rigorous and it is good. But as we go along, you see, there's also another bit. In as much as you are using percentages, as we go along, you realize that the numbers will keep going up at a faster rate because in terms of the recoveries. Now, we are getting a lot more people being probably taken into hospital care now compared to before. We also now have a situation where the testing regime is going to be faster. And then as we get more people into the hospital care, the records are showing that their recoveries are better and faster than those who are getting the home care.
Okay.
So once we ramp up, naturally the numbers will start
I need to
up.
point out to all of you that so far, all the recoveries have come from the general surveillance group. Nobody under the mandatory quarantine has recovered. Nobody under enhanced contact tracing has recovered. Nobody in those 2 groups has died. Nobody in those 2 groups is even critically ill. So all the interesting developments are in the first group. So it looks like the people who clinically show symptoms are the ones who are either seriously sick and recovering and dying. The other 2 groups are just there. Because we've had this, mandatory quarantine has been there for over 6 weeks. No recovery, no death, no critical.
You see, these are some of the challenges with the approach we are using, i.e. the way and manner, the delays occasioned in terms of trying to get results to update records happened. And then, of course, once initially a lot of people went into home care, and at some point some of them were lost up to the follow-ups. They were lost within the process. Then what has happened is that some of these records will now have to be updated properly.
Okay. Let me go to the panel and do the 3rd question. So far, I've asked about 4,700 mixed response, 10% recovery, mixed response. But this one, I'm sure it should be unanimous response. Case fatality rate, I'm on the Johns Hopkins dashboard. Ghana's case fatality based on 22 deaths is 0.5%. It was 0.4 2 days ago. It went up to 0.9. The maximum it's gone to is our 1.1. It's always been lower than 1. Almost all countries in the neighborhood have a higher case fatality than Ghana. The average global case fatality is about 5%. We are very low. Again, back to Dr. Tichi. Should we be smiling all the way to the bank because of our low case fatality?
No, Bernard, and I am rather worried about the perception that we have a low case fatality rate because of my experience in the hospital. Now, one thing that can give us this perception of low case fatality rate is a selection bias. Now, so we are testing a lot of people in the community, but I don't think that we are testing that many people in hospital. And patients who come to hospital who are ill are the more likely to die. So if the testing in hospital is not high, then you're going to miss people who are ill. And in my practice, there are patients we have seen who are ill, and we suspect that they could have COVID-19, but we've not been able to have access to testing. The second reason we should not be overly happy about our low case fatality rate is that if there's a delay in the onset of illness and death, so you come to hospital, and we know that patients with COVID-19 can deteriorate rapidly and die. So if this testing is not available in the hospital and you come and you are not tested and you die, you would not be counted as one of the deaths. And again, I have seen this happen in hospitals. The other reason is that, the way you count the deaths are different. So some countries, so you can die from COVID-19, which means that your death was caused by the COVID-19. So you had respiratory symptoms and you died. But you can also die, so you can die from COVID-19, which means it caused your death. But you can also die with it. So you come to hospital with something totally different, but if you are tested, you will be positive for COVID-19. Now, what's happening in hospitals again is that, people are trying to be selective in the testing. So if you don't, for example, have respiratory symptoms, it's difficult to convince people that you could have COVID-19 and so you should be tested. So again, if this is not done, we could also be thinking that we have a low case fatality rate. But also finally, again, across countries and in the sub-region, there are differences in the other factors that lead to death. So like things like health facilities, comorbidities, and these vary across countries. So yes, maybe we don't have too many elderly people in Ghana compared to some of these countries like Italy and the UK. And so in that, it may be low.
Okay.
But I am really worried because I don't think that we are testing many people in hospital who are sick who would end up dying. And so we are probably also missing some deaths.
That's interesting because we are supposed to be testing more than other countries in the sub-region. And yet you are saying our testing may not be enough to essentially rope in the deaths. So why is Nigeria with its lower testing having 143 deaths, Senegal with its lower testing 19 deaths, Guinea with 11 deaths, which is lower than ours, Cote d'Ivoire 21 deaths for 1,700 cases. So what are you saying?
That was a point I made earlier in my submission. So I am in a place like Nigeria, they are not doing what we are calling here enhanced surveillance, so that they are not going into the community and testing everybody like we are doing in Ghana. Their focus is on people who are ill first. So they are testing more ill people in hospitals. So they will find higher positivity. And of course, once they know these people are positive and they die, either from or with COVID-19, it won't be counted as a death. But if we are not testing that many people in hospital, and we are being, so selective in our testing, then we would miss patients who potentially were suffering from COVID-19, but were not tested.
Okay.
And so their deaths will not be counted or attributable to COVID-19.
Fair enough. Let me take Professor Yolson. What's your comment on the low case fatality?
Yes. You might think the low case fatality will be something to be happy about. It is not.
Oh.
It is not at all. Because if you have realized, every time we speak about those who have died from COVID, we say, and these people had comorbidity. I will tell you here and now, most people 50 years and above in Ghana will have comorbidity. And therefore, these people are acts. So anybody could be susceptible. So as we are saying, it is not something that we should be happy about. We should be aggressively, as Ken said, test all the potential persons who are likely, especially in hospital testing. And what has been started to be done is that all persons who are brought in there to any health facility should be tested for COVID. And even hospital patients who die from any known cause, even should also be tested for COVID, so that we are certainly sure we are not missing any death.
Okay.
Because that is critical. And again, it's because of the population we are talking about. We have seen that close to 5,000, it is affecting all facets, all age groups. And as I've told you, if we are not able to control the disease and it spreads wide in the society, we will have persons who are vulnerable, renal transplant patients, heart transplant patients, people who are severely immunosuppressed, and they are all out there. And that is why it is important that we prevent the spread of the disease as much as possible.
Let me make it more exciting for Dr. Grace. So, Doc, apart from the low case fatality, I am also quite aware, based on calculations, that our percentage of serious or critical cases is below the global average. The last time we checked, it was around 0.35. It's actually gone lower. So it's not just low case fatality of 0.5 or whatever. the percentage of those who are sick, who are critically ill, is also very small than most countries. Globally, the figure is 2.6. So surely, those 2 points should give you a bit of comfort, Dr. Ayensu Dankwa.
It doesn't give me any bit of comfort. And for the first time, I'm agreeing with my two panelists. In other words, the case fatality rate is low, but like both of them said, we are not really testing the in-hospital patient. So several issues. Number one is the access to testing. There's a lag in testing. So basically, I can give you a specific example. Someone I know is in a hospital who was a suspect of a COVID patient, right? They took his test on Monday, and the test was left in the hospital, and the test was picked up on Friday afternoon, which was 5 days or 7 days, 5 days later. So there's a testing lag. Meanwhile, the people in hospital who are supposed to be that 3% or the 2% of people that are going to be critically ill, just based on not the ones being tested. There's a lot. We know that the virus also affects people with comorbidities more. So the high blood pressure, the diabetes, and we also now know that the virus actually is not the fulminant pneumonia that the virus causes that is really the cause of death. It's usually, we're seeing now that people will get strokes and other type of embolic or thrombotic type of problems that will kill them or that will be the cause of death. Are we recording all those people as COVID cases? Because yesterday when the president spoke, he said, oh yeah, all those the 22 people that have passed or that have died is because they all had comorbidities and they already had some problems before. I feel like that is giving an excuse to say that, oh, because they have comorbidities and that is why they died. So it's not really the COVID that killed them, but their comorbidities. But maybe somebody had high blood pressure. The high blood pressure was very well controlled. They were taking their medicines. They were doing everything right. They were healthy. They were going to work. And then they got infected with the COVID. But because of their chronic disease or their comorbidities, they had already were immunosuppressed to a certain extent. Okay. And that is why they died. So the numbers don't make me feel any better. I know for sure that maybe there are other causes of death, like people who are dying of strokes, people who have died in the hospitals. We're not really testing. There's an issue in the testing lag as to when we actually test and when the report is done. And also not everybody has access in the hospital to testing. So our fatality rate might actually be higher than what we are reporting.
Good. Let me end this round with Dr. Youngson. Case fatality, percentage of cases critical, both well below the global average. GMA, happy with that?
Well, this may be a bit deceptive. If you just look at the numbers on the surface value, just like my colleague said, there are deep issues that we need to look at when we take that percentage in itself. They've mentioned a lot of them. But going forward, you realize that if all these preventive bits that we are talking about are not adhered to, and the system is overwhelmed, that is when you begin to see a lot more cases. If you look at the trajectory of events in countries that have had a lot of deaths, to start off with, at the point where the cases were not that huge, you realize that a lot of them were able to an extent, contain the number of deaths. But as they became overwhelmed, you get to points where people basically are home, ambulances are overwhelmed, they cannot go pick them up for any intervention, and they pass in their homes. You go into the hospital setup, you've had to share ventilators with others, and people at some point will have to make a decision, do I take somebody off and put somebody on? When we get to those levels, God forbid though, then you begin to realize that, look, the system is overwhelmed, and you begin to get a lot more deaths happening. So at this point, if you just look at it on the surface, you may think that, oh, we are doing so good, but that could be our Waterloo. we could look at it and think that, oh, with what is happening, people are not dying. Even the education that we are trying to do, you go out there and people say, oh, but nobody is dying in Ghana. What is happening around us? There's no disease, what have you. So these are the sort of things that we should be looking at.
Final question is on the numbers across the world. And Europe, 1.7 million cases, according to WHO. America's 1.7 million confirmed cases, very similar to Europe. Mediterranean, Eastern Mediterranean, 271,000. Western Pacific, 160,000. Southeast Asia, 102,000. Africa, 44,000. Africa is very low. Question, is it because the disease came here later? Because it appears that the times we got our first case, March 12, 11, that's the same time UK and Germany got their cases. Is it because our people are younger and therefore they are not getting the disease as much as the Europeans? Or is it because we are not testing enough? I'm going to give each of you just a minute and a half to comment on this and what this means, because this is the last question. Again, I'm going to start with Dr. Techi. Should Africa's low COVID-19 numbers be interpreted to mean what? How should we interpret our low numbers compared to all the rest of the world?
Well, Bernard, would wish that our numbers would remain low, but if we look at how this disease has progressed across the various continents, it is unlikely to remain low. I think that it is because we are not yet testing enough, just like many of the other continents you have mentioned. And this is why the West African College of Physicians is calling on countries in the sub-region to increase access to testing so that we can pick up more cases, both in hospital and the community, and prevent spread. And also asking that healthcare workers should be provided with appropriate PPEs so that we can continue to work, because COVID-19 is going to be with us for a while. Our numbers will go up, but we must be prepared to continue to provide service for other non-COVID-19 cases.
Okay. Professor Yosin, will our numbers get to the Europe numbers? We are 44,000. Asia, 102,000. Europe, 1.7 million. What is the meaning of our low number? And will we get to the numbers the other regions are experiencing?
I always say, disease in human populations behave in similar patterns. And therefore, what has happened elsewhere can happen here. What we need to hope and pray for is that it doesn't get that way. We need to aggressively go through all the preventive things that we have put across, because our health system already is stretched, is weak, and we cannot contain if we get a surge with a number of critically ill persons. And therefore, government of West Africa, through the West African College, we are entreating collaboration and cooperation across West African states, because this all for each. You cannot do it alone. You may do it, but your borders are still porous. People will come in from other countries. So through WAHO, through the Abidjan-Lagos Corridor Organization and other such international bodies, Afro, WHO in West Africa, the college is liaising so that we encourage international cooperation among governments to see this pandemic that is now evolving in our sub-region.
Thank you.
And we should go to sleep on that.
Dr. Ayensu Dankwa, you have a minute. What is your view about the low numbers in Africa?
Thank you. Before we go on, I want to say that I'm also a member of the American College of Surgeons. I'm a fellow of the American College of Surgeons, sorry.
Okay.
So I've been liaising and talking about what's happening in America. Anyway, I agree with what my panelists have said, because there's something I always say, that we have an advantage of a late start, as in Africa, because we saw what happened in China and in Europe. And so because of that, we can use what happened there to advise ourselves. The virus has not changed. It is the same virus, and it's affecting people or infecting people the same way. So what I see in Africa or in Ghana now is that we are not testing enough. Europe and America are doing something called mass testing. Mass testing is not what we are doing, what we call enhanced testing. It's completely different. Mass testing implies that if this area is noted to be, like the president mentioned, I think his last two conferences or his last two appearances, that we had, like Ayawasu West Wagon was a hotspot. Mass testing implies that you cordon off Ayawasu West Wagon and you go in and you test everybody, whether they are contact tracers or not. You just test all those people in that vicinity. That is what we call mass testing. We are not doing mass testing in Ghana. Europe, most of Europe is doing mass testing. America is doing mass testing. They haven't gotten to the numbers that they really even have to. So they are testing more. So that's why their numbers are good. Secondly, we need to provide the PPEs that we give to our frontline workers. Up to today, as of March, the president promised
Doc,
we have.
Thank you, Doc. I have to say thank you.
Stress on public education.
Fair enough.
And that's what is going to help the Ghanaian community.
Dr. Youngson, just give me 1 quick minute.
Well, Bernard, these numbers for us, for now, we should think that we are safe, but it is not. The disease starts gradually, you get to an exponential phase, and everything can go out of gear. Because we are not testing enough, like it's been said, we seem to have low numbers. But please, 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 West African countries should take advantage of this current supposed low numbers, educate their people properly, and ensure that we prevent further spread.
Okay.
The message here is prevention, prevention, prevention.
Let me read a few quick comments. Good evening, Bernard. Fine, we are doing more testing and the rate of which people are being infected is exponentially increasing. So should we continue tickling ourselves and laugh with praises and say we have done more testing, or find ways to reduce the community spread? Eric from Ashaiman, Amasaman. Can a family voluntarily go to hospital for testing of COVID-19 or what? Daniel from Takadi wants to know. I think we should be a little worried about our 10% recovery rate because we are not really thinking about the possibility of having a cure. Senegal and Guinea have gone for the COVID-19 organics of Madagascar. Our government should consult Madagascar and other countries to find out what they are doing. It seems you're only waiting for WHO. Lots of comments coming in. Time will not permit us to read all of them. We appreciate your time. Guests on Zoom, Dr. Kenneth Techi, General Secretary, West Africa College of Surgeons and Physicians, consultant physician. Thank you. Professor Alfred Yawson, Vice President of the Ghana chapter of the same organization, Associate Professor of University of Ghana Medical School, Head of Community Health Department. Dr. Grace Ayensu Dankwa, member of the NDC COVID-19 Emergency Response Team, politician, trauma emergency specialist. Dr. Justice Youngson, General Secretary, GMA, and a doctor as well. My name is Bernard Avle. We hope you've learned a thing or two. Stay safe, wear your mask, don't go out if you don't have anywhere to go, and let's work together to bring COVID-19 to an end. Stay with CTTV. We'll see you next time. Bye-bye.